It's my pleasure to introduce to you Dr. Cary Reid. He's a professor of geriatrics, and he's the director of the Office of Geriatric Research in the Division of Geriatrics and Palliative Medicine at Weill Cornell Medicine. So I've given you a clue to his expertise. There was a bio sent out with the lecture announcement that gave you information on his training and work experience. So I just want to highlight what he currently does and some of what he currently does. He does research on the prevention and management of pain in older adults, and also research on the use of technology to address negative symptoms in older adults. He is also a practicing geriatrician, and which means he's caring for patients in New York City. So you may have heard the phrase from bench to bedside. Cary does both bench, meaning the research part, and the bedside, meaning the seeing patients. So we call, it's called translational research, what the area he's in, where you're translating research results to patient care. Cary is also an old, as in longtime friend of mine for probably 40 years. And that means I get to add a few tidbits about his bio that you're not going to find on the website at Cornell. He went to graduate school in the mid-70s with my husband, David Weinstein, who's here in the audience, front row, and they were both getting their PhDs in ecology at the University of Tennessee. So if having a PhD and an MD is not enough to impress you with Dr. Reid, then I will give you one more tidbit. He used to play the hammered dulcimer, and one summer, he entertained guests with his old-time band, we're talking banjos, fiddles, and dulcimers, at Dolly Parton's Dollywood theme park in the Smoky Mountains. So if it was hanging out with Dolly, or if it was exploring ecology that propelled him to his distinguished career as a medical doctor, we can only guess. So we're going to give him a warm welcome in just a minute, and the title of his talk, if I can remember, is The Ins and Outs of Cognitive Aging, What's Normal and What's Not. Now, the challenge for those of you in the Kendall Auditorium is that we cannot make his slides come up on the screen. So we're going to give you a cognitive challenge today of using your imagination for what is on the slides. And just to reassure you, we've got the slides on the Zoom. We are recording this lecture. So after you hear it here today, you can go back and watch the recording, which will have the full slides for you to see. This is the best we could come up with today. And we're so happy you're here and hope that you can, go with the flow with this situation. So please welcome Dr. Cary Reid.
Okay, well, it's a real pleasure to be here with you this afternoon. What I'm going to do over the next 40 minutes is go over some core cognitive domains. So when you go see your physician and they're going to do a cognitive function assessment, what are those domains that get louder? What are those cognitive domains that get assessed? I'm then going to move into the major categories of cognitive aging. So cognitive domains then move into the 3 categories of cognitive aging, highlight factors that have been posited to reduce cognitive decline that we all want to pay attention to, and perhaps most importantly, then move to questions and answers. Okay, so as Christina said, I'm a geriatrician practicing in New York City. The mean age of my patients is 86. They range in age from 70 to 105. We have many centenarians in our practice. I am not, so I'm a primary care physician delivering geriatric care to older adults. I'm not a memory disorder specialist. But what are complaints that people come to me with on a regular basis? I'm going to give you some of them. I frequently forget where I put things. I went into the room and could not remember what I went in there to do. This kind of thing happens more than I would want. The word was on the tip of my tongue, but I just couldn't come up with it. I was talking with a colleague I've known for years, couldn't remember his name for the life of me, couldn't recall it. My sister was just diagnosed with Alzheimer's. Should I get tested? So these are common complaints that patients come in with. Sometimes it's not the patient, it may be the adult child, it may be the spouse that's reporting these problems. But what's underlying those questions are really 3 key things that physicians do. The first is They're worried. Is this a sign of Alzheimer's disease? So that's diagnosis. Help me. Is this a diagnostic issue I should be concerned about? The next question is, what does it mean for my future? That's a prognostic question. What's the future hold for me? And then the last question that often comes up is there anything I can do to stop it from getting worse? So that's prevention and treatment. And we're going to cover each of these in just a second. So as I mentioned, memory problems, significant source of worry, not only for patients that come into the practice, but their spouses, their adult children. And we have to recognize with cognitive aging that this constitutes a significant public health challenge in the 21st century. So between 2000 and 2010, the curves flipped. The first time in recorded history that the number of older adults, or the percentage of older adults in a population, outpaced the percentage of kids under the age of 5. First time in recorded history. So you've seen the demographic trends in terms of what is projected over time. In 1900, fewer than 5% of the population was over the age of 65. Now it's about 15%. Some people project that in 2050, that number may increase to as 25%. So we constitute, and I'm in that age category, a growing proportion of the population. Now, I'm sorry that those in the audience can't see this joke. It's from the New Yorker, and it's one take on memory loss, and one person says to the other, trying to retrieve words we can't think of is really the bond that holds us together, isn't it? Now, here's a literary take on memory loss. The name of the author is the first to go, followed by the title, the plot, the heartbreaking conclusion. Then the entire novel, which suddenly becomes one you've never read, never even heard of, as if one by one, the memories you used to harbor decided to retire to the southern hemisphere of the brain to a little fishing village where there are no phones. That's a poem from Billy Collins, one of my favorites. So there are 3 buckets that in 2023 we use to classify cognition and memory. And the first is something that we call normal cognitive aging. And I want to emphasize the word normal. It's normative, and we're going to go over some data to support that. The next 2 are not considered normal, and they include mild cognitive impairment. And then the third and most concerning category is Alzheimer's. So before we get into each of these categories, I want to briefly go through the cognitive domains that get tested to help us understand whether somebody fits into one of those 3 buckets. And these categories include the following. The first is a term I think most of you know well, executive functioning. And what does that term include? It includes our ability to plan and problem solve, to think abstractly, to do reasoning, to make decisions, and to behave appropriately in social situations, thought to be subserved by the frontal lobes. The next is language, simple thing that we use all the time, right? Our ability to produce and understand speech, to read and write, to name objects, our ability to retrieve words and use them appropriately, verbal fluency. There are a number of subcategories of memory. I want to go through each of those. So recall, can we recall something without being prompted? Something called recognition memory, which is the ability to identify information as having been encountered previously. Have we seen it before? Semantic memory is the ability to recall and make use of concepts, facts, ideas that have been accumulated over a lifetime. That often goes into the bucket of general knowledge. There's autobiographical memory, our ability to recall our own past, and then something that also goes in the memory bucket that's called implicit learning, which is our ability to take in new information without being consciously aware of it. A fourth cognitive domain is attention. Are we attending to others? Can we hold on to that stimulus that's coming in and sustain our focus? In the old days, this would be called visuospatial abilities. It's now termed perceptual motor function. It's the ability to understand space in its multiple dimensions. And within this category, we have two important subcategories. The first is object perception. Can we recognize familiar objects and faces? Do they come to us? Do we recognize what they are? And spatial perception, which is the ability to locate accurately physical objects in space. And one of the things you may have noticed in people with cognition problems, cognitive impairment is a known risk factor for falling. And it's posited that one of the reasons why is their spatial perception, their ability to sort of see where things are in space, it decrements over time. Also within this category is the ability to judge the relationship of objects, sometimes moving objects, correctly. And this gets into our ability to drive. The last domain, and the one that has been most recently added to the 6 cognitive domains, is social cognition. This idea of our ability to recognize emotions and respond appropriately in others. So all of these things we need, and we need them to work together to help us understand, to remember, to learn new things, to solve problems, relate to others, and make important life decisions. So when you go to the physician's office and they're going to pull out that paper and pencil test, I'm going to go over one of the tests in just a minute. These are the kinds of tests that get administered in the primary care doctor's office. And also that doctor might want to say, I'd like to speak with somebody who knows you well to get additional information. That's the informant. Your physician may say, I'd like to send you to a specialist. They're called neuropsychologists. The neuropsychologist will administer a very extensive battery of tests where they can then look at your performance relative to people like you based on age and education. But a big concern about all of these tests is whether or not they can accurately capture our functioning in everyday life. So they're paper and pencil tests. They ask you how many words you can come up with over a minute. But do they really capture things like your ability to use a money machine, to drive, and to manage your medications successfully? So I'm sorry that the people in the audience cannot see this slide, but I have on the slide what is perhaps the most commonly administered cognitive assessment in primary care. It's called the Montreal Cognitive Assessment. I'll go through it quickly. It asks things like the ability to recognize objects, to be able to take a cube and copy it correctly. There's a clock drawing test where you were asked to replicate a clock, put all the hands of the clock in and the numbers and assign a time. That's felt to be an executive function. There's memory where they give you 5 objects, face, velvet, church, daisy, and red, and ask you to recall those. Attention is on this test. So you're given a set of numbers and asked to recall them. There's a serial subtraction where you're asked to subtract 7 from 100 5 times. There's a language test. And then there's delayed recall. After 5 minutes, those 5 words, face, velvet, church, daisy, and red, you're asked to give them back. And then finally, there's orientation. Are you oriented, which is a kind of memory? Do you know what season it is? Would you know the day? Would you know where you are located? So in this test, they allow for up to 4 incorrect answers. So that's kind of normal cognitive aging. And I'll talk more about that in a minute. And the worse your test score, obviously, the more impaired you are. If you have limited education, you get to add some points. So what I'm going to do now is shift to what we know based on studies that have looked at cognition over the life course. So the first is memory. And when we take people from the age of 20 and we go out to 90 and beyond, you can't see the curve in front of me, but what I can tell you, it's doing this. Memory function does decline with age. And you would say, well, how much? And it turns out if you're about 90, that decrement is about 30% reduction compared to the entire mean sample that's been done. So it is some kind of decrease. And we see the same with reasoning when tests are administered to capture reasoning. And we see it with processing speed, how quickly we can take information and manipulate it and do something. So all of those show an age-related decline over time. But we have to also account for the role of experience as a moderating factor. So there was an important study, very classic study, of skilled typists. We don't have typists anymore in the workforce, but the typist ages range from 20 to 72. And it turned out that the older typists surely did perform more slowly on standard measures of reaction time and key tapping, which would be processing speed. But it turned out that their typing speed remained the same. And the authors posited it was the experience that they had through a lifetime that allowed them to make up that kind of difference. So we have to think about the role of experience as a buffer to our decrements in these cognitive domains. The one cognitive domain that is stable or goes up over time is vocabulary. Very documented in many, many places. The one point that I want to make, and you can't see this slide, a key take-home message is there is tremendous variability within each person, within each person, and across individuals. And that is a hallmark of aging. So some of us are cognitively aging faster than others. Some are in fact improving. So to summarize this part of the talk around normal cognitive aging, in most cognitive domains, performance does decline with age, but not in all, and in particular vocabulary. Decreases in processing speed is the most consistently documented finding, but the declines are not linear. They're very dynamic. What you see often is a decline followed by an improvement, or you see somebody that may be declining more. We also have lots of evidence where people improve over time. So cognitive change is not the same for everyone. What might explain decrements in cognition over time, over age? It turns out that the number of brain cells or neurons are the same, irrespective of age, but the synapses, which are the parts of the brain that allow the nerve cells to communicate with one another, that's where it's felt the problem to be. And synapse function and number do decline with age and have been associated not only in animal studies, but human studies with decreases in performance in memory and other cognitive areas. So I've talked a little bit about some aspects of variability of cognitive performance. Genetics play a role. And historically, we've thought we can't do anything about genetics, but it turns out, you've seen some of the recent reports, we're now having gene therapies for people with sickle cell. We're starting to see them in other domains, and they are being used in preclinical studies in dementia. I want to introduce the concept of cognitive reserve. Some of you have heard about. So some individuals are able to maintain normal cognitive function despite substantial brain injury or findings that are consistent with Alzheimer's disease. How could that be? They have pathologic findings that suggest they should have Alzheimer's disease, and yet they don't have any of the clinical manifestations. Cognitive reserve is the concept that has been posited to explain this kind of phenomenon. And what are the factors that underlie cognitive reserve that help an individual build a resilient and more vibrant neural network that protect against injury and disease? There are things that are potentially modifiable, like educational attainment, like cognitively participating, having a cognitively demanding occupation. Leisurely pursuits fall into the category of cognitive reserves. Exercise does, and socialization. So these are all modifiable. So greater levels of cognitive reserve, both in number and the amount of time one spends participating in that activity, have been strongly associated with less cognitive decline. Now, what I'm about to say is very important for you or a loved one who may be starting to experience some memory issues. And the first is, lots of chronic medical conditions can negatively affect cognition. Things as simple as hypertension, heart failure, diabetes, being overweight, all of them have been linked with poor cognition. And you might be able to modify those conditions and improve cognition. Lots of medications that are prescribed and some over the counter have been conclusively shown to decrement memory. Sleep disturbance, when we don't sleep well, our brain suffers. Affective disorders, so depression, a recognized risk factor for poor cognition as well as anxiety. Hearing and vision loss, key sensory factors strongly associated with memory problems and are potentially correctable, and something called negative aging stereotype. So I mentioned about the medical conditions that are potentially could be brought under better control. And what might be the mechanisms? Well, for things like heart failure, if you have less perfusion, less blood flow to the brain, that can cause the brain to underperform. With bad control of diabetes, you can have neuronal cell death. There's oxidative stress, free radicals, which damage tissues in the brain, and something called neuroinflammation. So better treatment or prevention of chronic medical conditions could lead to improved cognition. Very importantly, to take a stock of what medications you may be taking or your loved one, because as I've said, many routine medicines used to treat urinary incontinence, to help people sleep, to treat hypertension, to treat depression, to treat Parkinson's, to treat allergies, have been found to have what are called cholinergic properties. And what that anticholinergic properties, and what happens is they interfere with the neurotransmitter acetylcholine. And so simply stopping these kinds of medicines, sometimes we see people's memory improve markedly. So it's important to do a careful review of medications when anytime memory impairment starts to happen. Also, general anesthesia been a risk factor for cognitive impairment. And you've heard stories about people undergoing general anesthesia and saying that they're not the same. So we talked about vision and hearing loss. And I'm going to move on because often the studies that document that a factor may be associated with something we don't want, like memory loss, come from observational studies. And that's not terribly strong evidence because there may be other factors at work. The strongest evidence comes from randomized controlled trials. And I want to go over briefly, this was just published back in September, the first and largest study to look at the potential efficacy of hearing aids for people as a protective agent or activity against hearing loss, or rather cognitive loss. And so they enrolled about 1,000 people. They were all over the age of 70 up to 85. Half got hearing aids and the other half just got some education. 50% of the people came into the study with some cardiovascular risk factors. The other 50% didn't. And the outcome was looking at change in cognition over a 3-year period. That's a pretty long follow-up period. So it turns out that in the entire sample, they didn't see an effect, but when they looked within the subgroup that had cardiovascular risk factors, hypertension, diabetes, obesity, heart disease, they saw very strong protective effects. So this is the strongest evidence we have today that hearing aids, in fact, can be protective from a standpoint of cognition. You know about aging stereotypes. We're witness to ageism all the time. We're witness to it in the press, in the social media. It's disparaging beliefs about an older person's abilities. And so Becca Levy and colleagues asked the question, if somebody thinks that their brain is not going to work well later in life, what impact may that have on their own cognition over time? And so they looked at this in a study where they measured this negative aging stereotype about cognition, asking questions like, do you think older people are absent-minded? Do you think older people can't concentrate well? And it turns out the more often a person endorsed those kinds of beliefs, the more likely their cognition decremented over time. So this idea of self-fulfilling prophecy, if we think things are going to get bad in the future, they may well do that. Now, as I mentioned, there's a lot of variability in cognitive aging, and there are people who are sitting way out on the curve who are doing very well, and scientists have called them cognitive superagers, and is typically defined as a person who's performing better than a person 30 years earlier than them. Okay, so that's a cognitive superager. And the National Institute of Aging has a number of studies where they're looking at people in that part of the distribution to see if they can learn factors that may inform the thinking about, well, how is it that they do so well? And can what they learn be translated to everybody so that we can all do better? So cognitive superagers. So again, to finish up this part of the talk, if you or a loved one are starting to experience memory loss, really think about a checklist. Are there chronic medical conditions that may be playing a role? Is there a sleep problem? Could that person be depressed or anxious? Could they be on a medication that's explaining it? Is there a sensory impairment that could be playing a role, either hearing or vision? And could there be the idea that this person has a negative aging stereotype? So I want to move on now to the second category called mild cognitive impairment, which is not normal. The first thing that I want to do is tell you a little bit about how it's diagnosed. So how does somebody get the label or the diagnosis of mild cognitive impairment? They have to have an impairment on one of the standard cognitive tests in at least one cognitive domain. Their cognition, the problem, the decrement, and whatever that cognitive area is, has to be corroborated by somebody. So the doctor just can't take their word for it. So the spouse or the adult child has to say, yeah, this is happening. It's not causing that person to be able to do their activities of daily living. They're still getting along and doing all of those things well, but it's a change from how they used to function. And there are two major subtypes. The first is it's just memory, just affecting memory. But we also know now that there's what's called a non-amnestic category, which means it could affect one of the other 6 domains that I presented earlier. Some risk factors: lower education level, the vascular factors that we've talked about, like out of control hypertension, diabetes, obesity. If you have a stroke or heart disease history, lipoprotein E4 genotype, and advancing age. All of those are risk factors for mild cognitive impairment. Now, here's a key part, though, about people who get put into this category, this bucket of mild cognitive impairment. Up to 50% of them come out of the bucket and return to normal cognitive aging. It's dynamics, right? People are improving. It isn't a death sentence that once you get there, things are only going to get worse. Somewhere between 5 to 10% of people who get this label, though, do move into the dementia category. And I'll talk about that in a little bit. Why is there so much variability? Why do a lot of people come out and other people progress? Well, there are different measures that are used. They're not standard measures. The diagnosis is still largely a clinical one, so there's variability there. And as I mentioned, cognitive functioning is a very dynamic process. So the recommendation here, just like for normal cognitive aging, when you start to see decrements, think about whether there could be a chronic or acute medical problem. Is a sleep disturbance going on that could explain it? Does the person have depression or anxiety? Hearing, eye problem? Are there medications that could have caused that person to get into this category? And could there be vitamin deficiencies? So what do we do when a person gets this label? Well, we certainly work to see whether risk factors could be modified and improved. If depression is present, we're going to treat. But it turns out that the government our government, through the National Institutes of Health, has looked at a number of medications and other activities to see whether people in mild cognitive impairment, their decrement over time can be slowed down. It turns out that there's not a lot we can do for this category. Now, I want to move on to Alzheimer's disease and related dementias. How do you diagnose this condition? Well, you have to have impairment in one of the 6 cognitive domains that we've gone over. But unlike mild cognitive impairment, the level of impairment has to be sufficiently severe that the person is now not able to do everyday activities. They're finding it difficult to shop. They're having a difficult time organizing their medications. They may be making bad decisions with finances. The deficits need to be confirmed by an informant, like the spouse or an adult child. It has to be a change from their baseline, their normal level of functioning. And we can't come up with another explanation, like a delirium or depression, to explain it. Alzheimer's is the most common dementia, and it counts for maybe up to 65 to 70%. Next comes vascular dementia, something called frontotemporal dementia, and then dementia with Lewy bodies, and then finally Parkinson's disease. Now, you can have more than one kind, so often you see coexistence across these categories. Risk factors, low education, the vascular risk factors that we've talked about, and then things like depression and physical inactivity, social isolation, smoking, and genetic risk factors. So I'm going to skip this slide and say, who often reports memory problems? Well, it turns out that family members are far more likely to come in and say, I'm worried, than the patient. Patients with dementia often are blissfully unaware of their deficits. So this idea of subjective memory loss, I think I'm losing it, is not a very strong predictor of future cognitive problems. In contrast to a spouse or an adult child who knows that person as well and says, no, this is not the same person, that's a much stronger predictor of future decline over time. Now, the course of dementia, one of the key themes, key takeaway messages here is there's a lot of variability in how our memory performs, and this is true in dementia. If you come down with a diagnosis, you're given the diagnosis after the age of 80, your course is a much more benign and indolent, much slower progression over time, as opposed to getting it early, or if at the time of diagnosis you have some concerning what are called neuropsychiatric symptoms, and those are things like agitation, aggression, and psychosis. From the time of diagnosis, the average life expectancy is about 10 years, but it varies greatly from as little as 3 to as much as 20 years. What causes Alzheimer's disease? Now, folks in the audience are not able to see the slide, but what we have are things called senile plaques. And these are beta amyloid proteins that get deposited in clusters in outside of the cells themselves in the brain. So it's an overproduction of this protein in the brain and the brain's inability to clear the protein. And this causes the brain, the nerve function not to work well. The other classic hallmark pathologic finding is something called neurofibrillary tangles, which are abnormal accumulations of a protein called tau. They collect, unlike the beta amyloid, inside the nerve cell and can lead to nerve cell death over time. A little bit about treatment for dementia, in particular Alzheimer's disease. We've had now for 3 decades what are a class of drugs called cholinesterase inhibitors. And early on, and this was in my training as a physician, these drugs were marketed as a kind of drug that could keep people functioning better, improve their memory and other cognitive domains, and keep them out of nursing homes. It turns out that almost none of that is true. The benefits of this class of drugs are very, very modest. And I would estimate that maybe 1 in 6 people who get the drug really have some benefit. So most people who get it don't benefit. It tends to be used in people with mild to moderate dementia, not advanced. The next class of drugs are called, there's only one in the class, memantine. And its benefits, like the cholinesterase inhibitors, are felt to be pretty modest. The good news about the drug is it's pretty well tolerated. There are very few side effects. If there's going to be benefit, it tends to benefit people in the more moderate to severe stage. So often physicians, patients will say, well, don't just stand there, do something. So clinicians will give these medicines even though there's evidence to support the idea that the benefits are not likely to be great. Now, you've read in the news, and I think we don't know, the jury's still out here in terms of the promise that will come from this new class of medicines called monoclonal antibodies. But they're the first class of drugs to actually target those protein plaques that build up in the brain. The other classes don't do that at all. The other thing that's notable that I want to share with you is the first class of medicines to be approved in more than 2 decades. So we've been struggling with our treatment options for over 20 years. A study that was published in one of the high impact journals back in the summer, JAMA, Journal of American Medical Association, looked at a drug called donanemab, which is in the class of the monoclonal antibody. And they randomized about 1,800 people to either getting the medication or a placebo. And it turns out that there were pretty good effects. 50% of the people in the treatment group showed no progression of disease versus about 30% in the placebo group. So that's pretty good. Now, also they did imaging studies of the brains of these people, and they were able to show a striking decrease in the plaque formations in the brains, which would support this idea of how the mechanism of effect is happening. Importantly to share, about 3% of the people in the treatment group had pretty serious side effects, and there were 3 deaths. The downside, there's the downsides. The other downside is the drugs are very expensive, about $60,000 a month. So, but Medicare has approved use of these medications. So right now, where we stand with this medicine is a class of medicines. We're still accumulating evidence, and most of the use of the medicine really is restricted to very specialty memory care units. Now, another important point is our science is advanced to the point now where, through what are called biomarkers, we can identify people with pretty good precision in a preclinical state. We can do through what are called brain imaging, positron emission tomography test, or PET scans. We can find plaques in people who don't have clinical manifestations of dementia. We can also put a little needle into the spinal canal and get out a little fluid and look for protein accumulation and find the tau and amyloid protein. Now, these tests are not 100% accurate because I've shared with you already that some people have plaques in their brains and function normally cognitively throughout their lives, but others do. But because we still struggle with our treatment options, a key question is, should we be trying to diagnose people and find people in the preclinical state of disease? And that's an unanswered question. I can tell you the U.S. Preventive Services Task Force has weighed in on this and says there's not sufficient evidence to currently screen for people in this state. That may change with more evidence. A couple of things that I do want to point out. People with cognitive impairment are at extreme risk of financial exploitation. Financial exploitation, some of you have been impacted or know people who have. It's a multi-billion-dollar industry. Each year I have 2 or 3 patients who will come in, or their family members will come in and say, you know, Mom, she just gave away $20,000. She trusted this person who was impersonating a bank officer. She was trying to do the right thing. So people with cognition problems can begin to make poor decisions. And obviously we want to be able to try to minimize that person's risk of experiencing that, because it can be profound in terms of its impact. We also know that our ability to detect a person's ability to either withstand or not these kinds of deception activities are not what we want them to be. And there's exciting research that's happening now in multiple places, including the University of Florida, where they're actually doing training and then sending individual texts and phishing emails to see if they can pick up. So it's a way of really trial by fire. So prevention efforts are key here to minimize the risk of financial exploitation. If you do have a loved one who is experiencing significant cognitive problems, it's important to have a conversation early with someone they trust about assigning a financial power of attorney. Absolutely important. And as many of you know, there's an expanding industry out there that for a fee will track bank accounts and credit cards to look for suspicious activity and help recoup losses if they occur. Now, excuse me, the third part of the talk, and I do want to leave time for questions, and maybe if we can run over a little bit, that would be good too. what can we do to prevent and slow down cognitive decline? What are some things that have been shown? So you can't see this slide, but this is a very, very active area of research, and things span from performing music. Choral singing has been looked at as a risk, rather protective factor. Lots of attention has been given to various diets, to physical activity, to reducing obesity, to engaging socially, to lowering lipid levels, to improving sleep and enhancing physical activity. Most, I would say 90+% of the evidence that has been generated to date about these factors have come from observational studies. They're important. But again, one of the things that we learn through these kinds of studies, you can find an association, but as this group knows well, an association doesn't mean causation, right? Doesn't mean that a cause-effect relationship has to be present. There could be a third factor that in statistics we would call a confounder that may be getting in the way of us understanding the true nature of that relationship. What we would like to do is have randomized controlled trial evidence, but that's hard, it's costly. You can't do these kinds of studies for years and years and years. And for things that might increase risk, like smoking and withholding education and forcing people to gain weight, we can't do that, right? You can't do that. So it's the best kind of design that we have to assure ourselves of a true cause-effect relationship, but not everything can be subjected to a randomized controlled trial. So in the last few slides that I have, what about physical activity? I'm just going to go over the big categories. Regular exercise consistently identified in multiple studies, regular exercise, to be a protective factor against cognitive decline. There are at least 2 meta-analyses. This is where we collect studies, and these are intervention studies, this limited number that we have, that found that exercise interventions can reduce decline in cognitively intact people and people with impairment. Now, not all studies have found that, but I think the weight of the evidence would support the idea that there's something going on with physical activity. The mechanism is probably through improving cerebrovascular health. So you're improving blood flow to the brain, you're helping to reduce the risk of diabetes, which is its own risk factor for poor brain health. There are many unanswered questions. Most of the exercise interventions that have been tested have been relatively brief, 2 to 6 months, and the follow-up periods have not gone on for years. A key unanswered question is, if exercise is good, when might it be best across the lifespan? Early on, midlife, late life? We don't know. What about diet? The focus has been mostly on Mediterranean diets. We all know about those, and something called DASH, which is dietary to stop hypertension diets. These are diets high in fruit and vegetables and legumes with low consumptions of saturated fats. There is randomized controlled trial evidence that diets can, in fact, improve cognition, but we've got a couple of others that have shown the exact opposite, no effect whatsoever. So the evidence is somewhat mixed about diet. But because diet can, in fact, help with other factors like reducing cholesterol, reducing hypertension, I think there probably may be something there. And so I don't think harm would come from amending and modifying a diet. So let me move on and say, what are the likely mechanisms? So many of the food groups that I mentioned have antioxidant properties, and that's felt to be one of the mechanisms by which these diets have an effect, as well as reducing vascular risk factors. Now, I'm addicted to spelling bee, which I think of as a cognitive training activity, and crossword puzzles, many of you do. So there's good evidence that doing cognitive training can, in fact, improve a cognitive domain. So when we give people interventions to improve memory, to improve reasoning, to improve processing speed, the studies are pretty unequivocal. You can improve function in that domain, but that benefit doesn't extend out to the other domains. It is restricted to that domain. And the key unanswered question about the cognitive training interventions is how long do they last? And it turns out that the current evidence would support rather short-term effects out to 2 years, 3 years. We don't know whether they persist to 5 and 10. So some unanswered questions there. So I think I've covered this. Again, what can we do to slow cognitive decline, which I think we would all say would be an important outcome and goal for many of us. Regular exercise, social engagement, making certain you get good sleep at night. If you're a smoker or you're around smoke, be done with it. Alcohol, what's the role of alcohol? Either none to up to moderate alcohol. You move beyond moderate alcohol, you start seeing increases in those cerebral risk factors, in particular stroke and hypertension, and sensible diets. As I've mentioned sensory impairment. So I just saw someone last week who came in, didn't complain of hearing problems, but I got from the daughter as I chatted with her after the visit, she said, Dad is at the table. He can't communicate in the conversation. He just sits there. He's not participating. I thought, I didn't test for memory. So he's getting a memory test. So modifiable. So this is the last slide, and then I hope we'll have some time for questions and answers. As I've hoped to have convinced you today, there is something associated with age, and that is that memory function and some of these other domains do decrement over time. Those decrements tend to be relatively mild, but they're consistent. The rates of decline are quite variable. And the kind of decline we see often is followed by improvement. So that process of cognition is a very dynamic one. If you or a loved one is experiencing cognitive decline, the first thing you want to do is look for possibly reversible causes. And then we've talked about the prevention activities that might help us to reduce decline and produce added benefits in the area of cardiovascular health and mental health. So I'm going to end there. And I think that leaves us some time for questions and answers. Thanks everybody for your attention.
Ask the question.
Are there questions? Are there questions from this audience? In the back? Yes. The question is there an autoimmune brain degeneration? Thank you for that question. Yes. So the mechanism is inflammation, neuroinflammation. And we do know that people with autoimmune diseases have higher prevalence rates of dementia and cognitive impairment than people without. So thank you for the question. The answer is yes, that's a risk factor for cognitive issues. Other questions or comments? Maybe some people.
I'm bringing the mic.
Yes, I will.
Okay. So I recently had hip replacement surgery for which I had general anesthesia about 4 months ago. And I very clearly experienced cognitive decline as well as lack of sleep and additional medicines, blah, blah, blah. My question is, since I couldn't prevent surgery, is there anything that other than time that reduces the risk of general anesthesia in the aging population?
Yeah. So the question is, this is a person who just went through hip replacement surgery and does feel that she experienced cognitive decline. What could be done to maybe minimize risk? And the answer is certainly the amount of time that you do experience or you are under general anesthesia. The other thing that comes into play for many people is complications, and this may not have happened to you, but complications during and around the surgery period where people develop what's known as delirium. And delirium has a way of unmasking cognitive problems and increases a risk for people to have persistent cognitive problems over time. So I think the answer to the question is the shortest amount of time possible under general anesthesia, and then the shortest amount of time possible in an acute inpatient setting. I don't know how long you were in the hospital, but hopefully it was a very short period of time. Question here? Yeah. So how inheritable is Alzheimer's? And you heard about the apolipoprotein E4 genotype, which has a documented association with impairment of clearance of amyloid protein. I would say it sort of doubles to triples a person's risk. But the good news is the relative incidence of Alzheimer's disease still relatively low. Now, to show my own memory issue, what was the second question? What was that second question? This is my own memory test. Oh, how much exercise? Thank you. That varies by guidelines. Moderate aerobic activity, 150 minutes a week, and that can be, split up in various days. But the more the better, I think. The more the better. Again, think about those benefits. They extend to helping people sleep. They lower blood pressure. They reduce cholesterol level. They reduce glucose levels. So they're working on all those vascular factors that we know increase risk for dementia.
Quick question here.
Yep.
So I understand that you're basically asking us to participate in this strange thing called the Kendall Marathon.
Absolutely. Yes, and it's an ultra marathon. The Kendall Marathon is an ultra marathon. It's not 26.1 miles. It's 100 miles.
Okay. All right. Very good. I'll take that.
Melissa, any Zoom questions? Oh, okay.
We have a question that says, which classes of medicines are of most concern versus benefit?
I would say, let me just say that the monoclonal antibodies cause concern for everybody. Real risk of brain bleed in these individuals, and you live with brain bleed, but it has its own impairment. So I think until I had a person come in this past week asking for the medicine, the spouse was behind it, and I said, I'm still not convinced that this is the right way forward, and refer them on to the memory specialist. The cholinesterase inhibitors, I think the side effects are relatively modest, and if you can't tolerate it, you're just off the medicine. So I think a trial is not unreasonable, even though, as I've said, I don't want to overpromise the benefits. Of the three classes, memantine is by far the best tolerated. One I left out because I had Christina said there are lots of slides here, and there were in fact lots of slides. Vitamin E, I would put that higher up on the list. There's some evidence to support the idea of vitamin E may have some benefit, and no evidence that it's going to cause harm. So vitamin E.
Question in the back. Okay, I will walk fast.
Looking a little at the future, what's your thoughts with the amount of drugs that are being used by a lot of people today that are available, illicit drugs, and what effect will that have eventually?
Yeah, it's a great question. We know the use of many of the illicit drugs are going up, particularly with baby boomers that are coming into the 65 plus category. I have to be honest, I don't know that we know a lot about their impact on cognition. We do know, in fact, I was at a conference this week where people were looking at cannabis use, and their hypothesis was it was going to impair driving ability. And it turns out that in that study, people who had more cannabis use were the safer drivers. Now, again, whether that was a cause-effect relationship, who knows? But I think it's a great question. And where I thought you may be going with that question was, what about the many, many medications? I don't know how care gets delivered in Ithaca, but let me tell you a little bit about care delivery in New York City. People will have a cardiologist, they'll have a pulmonologist, they'll have a gastroenterologist, they'll have the ophthalmologist, they'll have me as the primary care doctor. Many people have 6 and 7 physicians, all of whom feel very strongly they need to add something in the way of a medication to that person's regimen. So it's not unusual for me to see people who come in on 10, 12, 14 medications. And I'm going to tell you, when you have that many medications in your system, most of the time bad things can happen. So within the field of medicine, we're starting to see what is called a deprescribing movement. Can we start to back away from these medications? And do we realize benefits? You know, with the old Mies van der Rohe idea, less is more. And I think there's probably a lot there. Stay tuned, because you'll see a lot more about that in the coming decade. Thanks for that question.
Thank you. Thank you for the wonderful talk.
Thank you. Other comments or?
I'm going to take one here from Kendall, and then if there's another one on Zoom, and that may be the last question. So you go ahead here.
Well, I actually had two questions. One was whether a ketogenic diet can help repair some of the synapses. And the second was, how do you differentiate between some of the blank times that somebody who has inattentive ADHD and Alzheimer's?
Yeah, so the first is this ketogenic diet. I think there's some evidence, but as I shared with you, overall, I would say the jury's still out on the overall benefits of various diets on reducing risk of cognitive decline. The second is, now what about these other disorders that may get in the way of a person's ability to perform cognitively, like ADHD? And the answer is, it's a great question. You know, is that what may be driving a person's cognitive problems? I shared with you something that's even more common is depression. You know, is it the depression that's really the underlying reason why this person is struggling cognitively? And I can count on more than two hands the number of cases where successful treatment of depression led to very striking improvements. So the point that you're making is a good one. Let's look for other causes that may explain this person's cognitive impairment. And then we have a question from the Zoom.
So we have four questions
Four
from
questions.
the Zoom, if you would like.
Yeah.
So the first one is, what is Prevagen? Is there any evidence that it helps?
You know, there's no evidence that Prevagen is helpful, and I honestly can't remember what its origin is. I think it's a natural product, and I can't remember. Does it? Somebody here knows? I'm sure. So we don't. Okay. No evidence that Prevagen works, but it can harm the pocketbook. So there you go.
Next question, can seizures and anti-seizure medication affect cognition decline?
Yeah. So the answer is, can seizures affect cognition? It's not listed as one of the big risk factors, but seizure medicines, some of which I use as a physician that treats pain frequently. So gabapentin and pregabalin are in that anti-seizure medication class of medications. And yes, people will talk about cognitive slowing and fatigue and brain fog on the medicine. So the answer is absolutely. And this gets back to this issue of, you know, again, what's the checklist? Are there medicines that you're taking that could be the reason for a cognitive problem? And you need to go through them one by one.
The next one, how can we encourage our medical practitioners to address cognitive issues during doctor visits?
Yes, so everybody heard that question. I think in two ways, maybe more than that. The first is we need better training on the part of the physician workforce and nurse practitioners. Some of us see nurse practitioners. Most people aren't skilled and don't have the toolkit to do this. And so as a consequence, it isn't done. The other thing that needs to happen, I don't know what the average visit time is for you with your physician, but I can tell you by word of mouth, many people in New York City will say they're in with their doctor for 8, 9, 10 minutes and they're gone. So how on earth do you do a comprehensive assessment? Some of this can take place out of the context of an office visit, but so that's a payer issue, can we give physicians more time to do these assessments? That's a very good question with no easy answer.
Last question, related to earlier question, what about other seemingly unrelated but common medicines such as statins, antidepressants, high blood pressure medicine, etc.? Any particular classes to avoid?
Yeah, so statins, antihypertensives, and antidepressants. I want to go back to that term anticholinergic. So it turns out within each of these classes, the statins, in particular, though, the antidepressants and the antihypertensives, there are a number of medicines that have some anticholinergic properties. So a very simple thing would be, gosh, if you got on this medicine 3 months ago, you're starting to feel foggy, the brain doesn't seem to be working. The simple thing is to move to a different medicine. Medicines are fungible. The good news is there are lots of them. So always think about medication as a possible reason for cognitive problem. Thanks for that question.